Okay, so first I'm going to start with my machine check. I want to make sure that my auxiliary O2 tank is at least half full. And then I'm going to walk to the front, make sure my pipeline pressures are 50 psi. I'm going to make sure I have my suction, and then that's working. Make sure my ambu bag's working. I have my monitors, EKG, blood pressure, cuff, and pulse ox, and then my monitor parameters are on the right ones for my adult patient. Make sure my vent settings are on for the right patient when my ventilator's on, or my machine is on. And then while my machine's still off, I'm just going to do my low pressure test. And then I'm going to take a look at my vaporizers, make sure they're full, the lids are tight, and that the interlock system's working. And then I can turn my machine on. I'm going to make sure I can't create a hypoxic mixture. I'm going to look at my O2 or CO2 absorbent, make sure it's not desiccated. And then I'm going to look at my, do my O2 analyzer test to make sure that that is working. And then I'm going to do my high pressure test. So I'm going to close my AP all out to 70, press the O2 flush, make sure I can maintain 30 centimeters of water for at least 10 seconds, which I can. Make sure I can deliver a positive pressure breath. And then I'm going to look at my expiratory flutter valves to make sure those are working as well. And I'm going to have my Apple's drugs here just in case, and emergency and airway equipment as well. Okay, so first I am going to go talk to my patient. So this is Jenny Garrett. She's a 69-year-old female and a full coach. She has no allergies. She just has history of seasonal allergies, and she's here for a total hip replacement today. I have reviewed her labs in the chart as well, and then I have all my monitors set up on her, EKG, blood pressure, cuff, and pulse ox, and she's going to get 2 mid-as for some sedation. And then I'm going to gather all my equipment. I'm going to make sure my syringes, stopcocks, my 22 gauge needles, my sterile PPE, and make sure I have my ultrasound probe cover, and some gel. And then I'm going to do my patient assessment. So I'm going to ask her about recent cough or cold or anesthesia, history, and I'm going to do a full head to toe, auscultate heart and lungs, and make sure she has no history of neurodeficits such as like nerve injury and paresthesias anywhere that I need to know about, especially in the lower extremity for her hip. And then I'm going to do a full airway assessment as well. So I'm going to look at her Mallampati score, her thyromental distance, the incisor gap, and upper lip bite test as well. And then I'm going to ask her what she ate for breakfast, and make sure that she's on any medications I'm not aware of, or have any other chronic conditions that I'm not aware of. Okay, so first we're going to do our central line placement for her. So I have my supplies gathered for the central line. I'm going to don my mask and sterile gown and gloves, and I'm going to prep the patient. We're going to go in the IJ, so I'm prepping her neck. And then doing a timeout. I'm going to look at her landmarks. We're going to look at the sternocleidomastoid heads, and then the clavicle as well for the IJ. And there we are. And you can see the arteries pulsating, and here's the IJ. That's carotid pulsating. And then I can put in my wire, and if I move the ultrasound probe this way, I can see that my IJ fully collapses, and I'll be able to see my wire longitudinal through the screen on the ultrasound. Okay. So we're going to do a PENG block for her hip today. So the PENG block can target the articular branches of the hip, and we're targeting the femoral nerve, the obturator nerve, and then the accessory obturator nerves. Some risks of this procedure can be LAS, nerve injury, infection or hematoma, block failure or incomplete analgesia, and some contraindications include uncorrected coagulopathies, infection at the injection site, patient refusal or not cooperating, And then some relative contraindications are severe anatomical distortion, allergies, or sepsis. Benefits to this block, it's motor sparing, so she'll be able to get up and walk. And then it's superior pain control, has better patient satisfaction, and helps reduce opioid use. And then indications for like any hip or pelvic stuff, so hip dislocations, fractures, replacements, things like that. So alternatives for this, I could do like a femoral and fascia iliaca block, or I could just do general and then just use like normal post-op pain analgesia medications like opiates or NSAIDs or Tylenol. So I'm gonna get my patient positioned in supine, perform a timeout, make sure it's the right patient, right extremity, and I'm gonna prep her hip, do my sterile gloves, and next we're gonna look for our landmarks. So I'm looking for the AIAS, which is right here. And then as we go down, you can see the IPE, the iliopubic eminence. And then the artery is usually the easiest to find. Let's see. Yay, there it is. That pulsating thing. Okay. Yeah, and then you can see the IPE right there coming back, and then the psoas tendon, that little bright spot, IPE, AIS. Perfect. Okay. So for my needle approach, I'm going to be doing lateral to medial with the 22 gauge. And it's important to keep the probe kind of tilted caudally for this block. And then I'm using in-plane approach, and then the needle will go in between the psoas tendon and then the pubic ramus. And then I'll aspirate before I inject, and I'm going to do 15 to 20 cc's of ropivacaine, 0.5%. And then I'm going to make sure I'm getting adequate spread underneath that iliacus muscle, and then I'm going to do 5 ml increments. And not targeting the femoral nerve on there, but we're going for that femoral obturator and accessory obturator nerves.